on this effect site?
Yes, we have. We actually use a processed electroencephalograph, or EEG as it's abbreviated, called the bispectral index, which is just simplifies the analysis of the responses.
This isn't a very good quality of reproduction, but let me put.
Sorry, it's a Xerox copy.
So that we can see the title. Is this a study done by you?
Yes, it's done by my group, correct.
And what were you looking for in this study?
Well, we were looking for the correlation between the electroencephalographic value and an effect that we could assess in patients, namely level or depth of sedation, that is how sleepy they were. And if you turn to, I think it's the first figure, yes. And again, okay, I apologize for the very poor quality of the Xerox.
Could I?
You can zoom it in.
Could I mark this? Would it be X, triple X?
I think we're up to Zulu, Zulu, Zulu.
Okay, Z's.
The jurors agree. Triple Z.
Okay, on that study, I'm marking it Z, and on that study, there is a graph. Wow. And it's really...
If you can zoom in, I think it'll be okay. Yeah, that's...
Okay.
Move it over.
Let's turn off one other bank of lights, if we may, please, Mr. Sale.
And what I want to show you is on the y-axis here, the EEG, when it's converted or analyzed using this bispectral index
First
model.
of all, what's the y-axis?
The y-axis is the vertical axis.
And the x-axis?
Is the horizontal.
Okay, now you're talking about the y-axis.
The y-axis. This is the EEG bispectral index value, which ranges from 0 when a patient has no brainwave activity, that is a patient who's dead, to 100 when a patient is completely awake, would have no drugs present, and be alert like all of you this morning. And what the bottom, the horizontal axis represents is the level of sedation. Dr. Schaefer talked earlier about the OAAS scale. That's the Observer Assessment of Alertness and Sedation scale that's commonly used to assess effects of benzodiazepines and sedative hypnotics on the brain. When you have an OAS score of 5, again, you're totally awake, just like you all sitting here in the jury box. And as you give more drug, in this case midazolam, we gave small doses of midazolam to produce increasing sedation to the point where actually patients here at a score of 1 are unarousable. They appear to be not only sleeping but anesthetized, but they will arouse if you stimulate them vigorously. So as you go to deeper levels of sedation, you can see the average bispectral index, or BIS value, declines progressively, and then at this point we stopped drug administration, allowed the patients to recover. And similarly, as they went from a very deep level of sedation to minimal or no sedation, their bispectral index scores recovered. The reason I show you this is just to illustrate the type of variability that we deal with among individual patients. The dots represent individual patient values. And you can see here at very deep sedation or anesthesia, some patients had very low BIS values, but others had values that were consistent, if you will, with almost being awake. And the overlap is tremendous. We have patients here who were minimally sedated, but 3 of them here you can see had rather low BIS values. Just an example again of how we need to think about these kind of data when making interpretations.
So that line that goes through, there appears to be a line that goes through?
That's the mean at each of these levels of sedation. We did a mean, and just to show how it changes.
So that line represents the mathematical
average.
And that's what they use in modeling.
Correct.
But the dots show the variability from the model when you're talking about individual patients.
Well, it shows the raw data which goes into the model then to generate the various curves. So it's actual data.
Okay, are there studies that, you say this is midazolam, are there studies dealing with propofol and lorazepam?
Well, we have not performed a similar study with lorazepam, but if you go to the other paper by my colleague Dr. Liu, you'll see a similar analysis done with propofol.
I'd like to refer to ZC. Now we're 4A.
Lower quadruple alpha.
And this paper was published in Anesthesiology, and it looked at electroencephalographic bispectral index correlates and the correlation with recall and depth of propofol-induced sedation or sleepiness. And again, if you can
Were you
turn...
involved in this study?
Yes, I was a principal investigator.
And
This is a little easier to see.
I want to refer you to a diagram, and it's on page 3 of that study.
Again, the y-axis here displays the EEG bispectral index values. The scale is sort of compressed from 40 to 100. This is the relevant range for patients who are sedated or in anesthesia. Below 40 is not good because patients would be extremely deeply anesthetized. And again, this same observer assessment scale is used, with 5 being awake to 1 being hypnotized or unconscious. And what you see again is a lot of scatter among individual patients, although the trend is definitely, as patients become sleepier, the bispectral index value falls. But again, one sees that even in patients who were deeply sedated, one patient here actually had a rather high bispectral index value, and at this level of sedation 4, which is what we call minimal sedation, one patient had a fairly low value. So it just to give you a feel for the variability that we're dealing with when using the bispectral index as a measure of a drug effect on the brain. And the relevance of that will come in the subsequent study that I want to discuss.
Well, first of all, there's no line there. Is that just raw data without the mathematical model being drawn?
Yeah, that's just raw data, individual patients. There's no population averaging or modeling performed at all.
So
it's raw data.
It's basically the same as the last diagram we looked at that had the line, but except the line hasn't been inserted in this one.
Correct.
Now, you keep using the term bispectral index. Is there a way that you could just briefly explain what that means?
Well, it's terminology that was developed for compressing the EEG information into a numerical format that makes it easier for people to interpret and utilize in clinical practice. It's a complex program that's been developed and modified many times so that we don't have to have complex interpretations of multiple squiggly lines while we're caring for patients.
And the other study that you were referring to,
yes, this is the study by my colleague Daewoo Kim, looking at the relationship between various clinical endpoints, including the apnea, which you heard Dr. Schaefer talk about, and the bispectral index and effect site concentration values. And that's sort of why I wanted to give you that background, because in order to interpret this, I think it's important to have an understanding of what the purpose of analyzing the bispectral index is.
Your Honor, I'd like to mark this study as quadruple B.
Yes.
And you have a different type of chart on this. It's page 3 of the study, which is going to need some explanations. So that, what does that?
Well, in this study, we compared 2 different drugs, propofol to thiopental or pentothal. As I mentioned, that was the standard IV induction agent or anesthetic before propofol was introduced. And what this shows is a number of clinical endpoints. Dr. Schaefer talked about apnea, which was one of the endpoints that we looked at. We also looked at loss of verbal response, loss of the eyelash reflex, and when patients yawned as they went off to sleep. And what we show is the correlation between achieving this endpoint, for example, a loss of verbal responsiveness, and the EEG bispectral index value. So all these patients were at the same clinical endpoint, but as you can see, their EEG bispectral index value varied from 50 to 95. And just to show you the correlate of effect site, which I said was generated by these computer simulations, Mr. Flanagan, if you would kindly move to the right. Not you personally, but the paper. Again, stopping there, thank you. This shows, instead of the EEG bispectral index, it shows the simulated effect site concentration of propofol, which we've heard discussed many times. And here, looking at just focusing on one endpoint, because you see the same degree of variability at all of the endpoints, but this is loss of verbal responsiveness. Again, the effect site concentration varies from 0.04 all the way up to 1.2. So there it's about a threefold range of variability. For loss of the eyelash reflex, which is when we touch your eyelash and look for a response, it's often said to correlate with onset of anesthesia. Again, the effect site here varies from 0.45 up to 1.6, so it's about a fourfold variability. So again, just to give you some familiarity with the type of variability we're dealing with.
So in that, the dark circles are propofol?
Yes, the dark circles are propofol, the open circles are thiopental. It has the same variability, but that's not a drug we're discussing in this case.
Thank you. Now, when we left off yesterday, we were discussing Exhibit CC. And this is representative of Dr. Schaefer's modeling of the lorazepam as related by Dr. Murray in a statement to the police department. Do you recall that?
Yes, I do.
What does this represent?
Well, again, on the y-axis is lorazepam concentration, and on the x-axis it shows the time in hours after midnight. And it illustrates boluses of 2 milligrams administered at 2 a.m. and repeated again at 5 a.m. In addition, it shows the femoral vein concentration that was measured at autopsy in Mr. Jackson. And then there are 2 lines that Dr. Schaefer added relating to responsiveness to painful stimuli, and I think he has subsequently removed those because as I said yesterday, lorazepam is not an analgesic, so looking at painful stimuli it doesn't make a lot of sense to me.
Now, would you consider that the diagram to be accurate as it represents Dr. Murray's statement?
I think it's an accurate depiction of the average patient. However, one of the concerns would be, in accepting this as fact, would be it neglects to consider that Mr. Jackson, who had been taking oral lorazepam for many days prior to his untimely demise, it doesn't reflect any residual lorazepam. We know lorazepam has a very slow elimination from the body. I don't know if it was discussed. I think it was the elimination half-life, which is the time for the blood level to decrease by 50%, is on the order of 16 to 18 hours, so it takes a long time. So one would expect that if Mr. Jackson had been taking lorazepam for sleep in the days leading up to his death, that there would be some residual level, and this suggests there is no residual level.
Jackson makes much of to strike. It assumes facts not in evidence that Michael Jackson was taking oral lorazepam.
The objection is overruled. That's a matter for cause.
Now, but this assumes a zero, but hypothetically, if an individual was a .10 the day before, they would still have maybe a .05 or something the following day?
Could be.
Or if it's be basically half, maybe a little bit less than half of whatever he got to the day before.
Again, I'm not a pharmacokinetic modeler, so I would leave that to the experts.
And to refresh your recollection, you are aware of the statement Dr. Murray gave to the police that the night before he was put to sleep with just lorazepam and midazolam?
Yes, I am.
So from that, would you be inclined to believe that there would still be some residual left?
I would expect to find some residual, but since I wasn't informed as to the amount of lorazepam that was administered to Mr. Jackson the night or morning before his death, I can't make a judgment as to what I would expect to find.
Thank you. Now, I'd like to show you another exhibit, and I'd like to mark this as CC. Forces. Yeah, four Cs.
Mark?
And Dr. Schaefer,
White?
or Dr. White,
He's a lot younger, so I'm kind of honored that people are confusing us.
is that his a copy of what he diagrammed in his report?
Yes, it is.
And what does that depict?
Again, obviously the plasma lorazepam concentrations on the y-axis and hours past midnight. On the x-axis, again, the femoral concentration of midazolam is shown in the center. I've already commented on these other lines, which I find confusing and I really don't know how to interpret, but it shows a bolus dose of midazolam, 2 milligrams, administered at 3 a.m., and a second bolus dose administered at 7:30 a.m.
Now,
And the resultant average expected blood concentration.
Now, from those doses that are given at 3 and at 7:30, those are based upon the statement by Dr. Murray?
Yes,
Given to
they
the
are.
police? And I noticed that the midazolam, those slopes, they go down a little bit, they dip a little bit further than the lorazepam lines were dipping. Why is that?
Well, they decline faster because the elimination half-life of midazolam is much shorter. As I said before, the elimination half-life is the time for the blood level to drop by 50%, and it's a matter of 2 to 3 hours with midazolam, so it's considerably shorter.
So midazolam is a much quicker acting benzodiazepine. Is that correct?
It has a faster onset and a shorter duration of effect as a result of its faster elimination.
Is it the short duration of its effect that made it more useful than, say, lorazepam when you're doing pre-med for surgery or using it with respect to anesthetics?
Yes, it's more what we call titratable.
What's that mean?
It means achieving a given effect with a drug. The speed with which we can achieve a specific endpoint reflects the degree of titratability. And a drug like propofol, one of its most desirable features, it's very easy to titrate quickly to a given effect, and that's why it's become extremely popular for use in the perioperative period.
Now, would you agree with Dr. Schaefer when he represents that the statement by Dr. Murray with respect to the midazolam given at these times does correspond very, very nicely with the toxicology results that were obtained at time of autopsy?
Well, unfortunately, that last curve, if you go back, it doesn't show the midazolam concentration. So it's confusing, I'm sure, to the jurors because you're talking about midazolam and the axis shows lorazepam. But I think midazolam was on the other side of that graph. Am I right?
No.
Oh, it wasn't. Well, then,
I could refer to the report.
is that
if you-
confusing, or?
Well, if,
If you go back to the last graph, I just want to clarify that the blood level looks like it's far lower than the femoral blood concentration, but that's the femoral blood concentration actually for lorazepam.
Yeah.
And
This
you
is
see what
just-
I'm saying? This looks like it's much lower than the femoral concentration, but this is the femoral concentration for lorazepam, not for midazolam. I just,
let me just to clarify that, put on the actual diagram prepared by Dr. Schaefer in his report. So
but see, he doesn't show here that middle line, so.
Yeah. And the responsive only to painful stimulus and not
Oh, wait.
responsive to painful stimulus lines are much higher than they were for lorazepam also, aren't they?
Well, they are, but I don't know that they're particularly meaningful in the context of this particular drug because it's a benzodiazepine sedative hypnotic, which doesn't have analgesic properties. So I think in his subsequent illustrations, these lines have been removed.
And when you say it doesn't, no analgesic properties, it's not a pain reliever.
Correct.
It's just a sedative.
It's a sedative hypnotic, yes.
Thank you. Now, I want to show you another exhibit. I'm going to mark that exhibit D, D, D.
D. 4D.
And now this exhibit, that exhibit, does that purport to depict, based upon Dr. Murray's statement to the police, what Dr. Murray thought or told the police what he thought was in Michael Jackson's system that he had given that morning at the times indicated on the chart?
Objection, vague.
Do you understand it?
Based on the objection is premised on that Dr. Murray made a statement about.
I'm going to ask you to rephrase it.
Okay.
I think it may be a tad vague. Sustain.
Dr. Murray indicated that he gave Michael Jackson the 2 doses of lorazepam that would be depicted by it's supposed to be a red line, and the 2 doses of midazolam that would be depicted by the yellow line, those 2 doses, and that at approximately 10:30, 10:40, in that vicinity, that was all he had given to Michael Jackson that night.
I believe that's what he stated in his police interview, yes.
So now, he also told the police that at approximately 10:40 to 10:50, he gave a slow injection over 3 to 5 minutes of 25 milligrams of propofol. Is that correct?
Yes.
And of the statements made by Dr. Murray to the police, that last statement of the 3 to 5 minute injection of propofol was the only one that Dr. Schaefer, of his Dr. Murray's statements, that Dr. Schaefer did not diagram in his report. Is that correct?
Objection. Misstates the testimony. Dr. Schaefer diagrammed that at the request of the defense.
No.
And was introduced into evidence.
I'll repeat the question.
I think it has to do with report.
Yeah.
The objection's overruled. You can repeat it.
The only, of Dr. Murray's statements to the police, the only one he really didn't describe in his report that he wrote in April was the 3 to 5 minute dose of propofol at approximately between 10:40 and 10:50. Is that correct?
Yes, it is correct. But Mr. Walgren is also correct in saying that I requested Dr. Schaefer to do the simulation, and he kindly did it for me and emailed me the results. which I think were presented yesterday or previously.
I'd like to put previously marked triple E on the screen. And I want to show you that diagram. What is that diagram?
That's the diagram that Dr. Schaefer provided to me in request to a simulation of what Dr. Murray stated he administered Mr. Jackson on the morning of his death.
Now, that simulation right there, that's he put it on that chart, and the x-axis, does that indicates 10 minutes?
Oh, the x-axis, I'm sorry. Yes, that's minutes following the initiation of the bolus injection into the IV.
And the x-axis,
The y-axis is the propofol concentration that would be expected to result following the administration, well, during and after the administration.
and it shows that it reaches a peak level somewhere in the vicinity, both blood and
This is
his
blood.
And his anticipated brain level both reach approximately the point of 1.
Yeah, he simulates.
Please allow the whole question. I'm sorry.
1, and that would be micrograms per milliliter.
Yes.
Now, if you were to condense the time and put that graph on a next in order is EEE. If you could condense that slow injection over 3 to 5 minutes, you'd have to tighten up the slopes, wouldn't you?
Yeah, it would become more peaked, if you will.
Quadruple E.
And I want to show you quadruple E. Would the slope look something like that if you adjusted the time to account for the 0 to 12 hour x-axis?
I believe that's a reasonably good representation, yes.
Now, based upon Dr. Murray's to the police, his statement to the police on that day in question, on the June 27th, is that what he told the police that Michael Jackson had had that night?
The transcript itself and audio has been played directly to the jury. I don't think it's for this witness to interpret what was said.
The objection is sustained as to the form of the question. You can refine the question, taking what you just said into account.
These simulations, this simulation here, does it accurately depict what Dr. Murray, in terms of simulation, what Dr. Murray informed the police of?
Well, it's a simulation.
Go ahead.
It's a simulation performed by Dr. Schaefer, which I think is accurately depicts an average patient who had received.
Objection. This exhibit is not a simulation made by Dr. Schaefer. Counsel just indicated they added this peak.
The objection is sustained. The partial answer stricken. Please disregard. Re-ask, please.
Okay. The lorazepam and midazolam, those are Dr. Schaefer's depiction of what he thinks the benzodiazepines would be at the indicated times. Is that correct?
Yes.
The propofol simulation up there is basically your simulation based upon Dr. Schaefer's information to you of what the propofol would look like. Is that correct?
It's not my simulation. It's Dr. Schaefer's simulation. All we did in this illustration is just compress the time frame. So I don't want to take credit for a simulation that I didn't make.
Okay. Now, let's assume that what Dr. Murray told the police that day was accurate. Would this present a dangerous situation here?
Not at all.
Could you explain that?
Well, as as can be shown in many studies, giving small doses of either midazolam or propofol have very transient effects. The dose of propofol that we're talking about here, 25 milligrams, is equivalent to 0.4 milligrams per kilogram in Mr. Jackson. And that is a dose that might be used to produce a little bit of anxiety relief, a little bit of sleepiness, and has actually been studied for pre-medication of patients.
And who studied that?
Well, the paper that I refer to is by Rondo and Thompson, published in 2008.
And did you bring a copy of that paper to court with you?
No, but I hope you did.
Did you give it to me to transport for you?
Yes.
I'd like to mark that F, 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 Your Honor. This
Wait,
article,
there's another F, quadruple F.
I got 4 Fs there.
Thank you.
It's kind of
Marked.
like my military capability, Your Honor.
Quadruple foxtrot.
Is that the study you're talking about?
Yes, sir.
And what does that study involve?
Well, it was a clinical, randomized, double-blind, placebo-controlled study where patients were administered either propofol, 0.4 milligrams per kilogram, midazolam, 40 micrograms per kilogram, which I will just tell you is kind of a standard dose that we use prior to surgery. 20 to 40 milligrams is the typical dosage range for midazolam. And there was a third group, which was a control group that got a placebo. So it was a properly conducted, randomized, double-blind. The observations were made by blinded observers, and they looked at things like anxiety level, respiratory changes, blood pressure changes, other side effects of the drugs, like whether the patient had dizziness, over a period of time prior to going into the operating room and undergoing general anesthesia.
Now, is this on monitored patients?
Yes, these patients were all monitored in a study unit environment.
And the amount of propofol used was what?
0.4 milligrams per kilogram, which is, in Mr. Jackson, would actually be 25 milligrams or 24 milligrams.
So on a person Mr. Jackson's size, 25 milligrams would be the equivalent of what was used in this study as a pre-med?
Yes.
And would that be considered anesthesia, conscious sedation, minimal sedation? What would that be considered?
That's what we call minimal sedation.
Your Honor, I have another chart that's entitled Continuum of Depth of Sedation, Definition of General Anesthesia and Levels of Sedation Analgesia. I'd like to mark it G, 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 G.
Quadruple golf.
I'm showing you what's been marked as G, quadruple G, and I'd like for you to explain to the jury what this chart is.
Could you just drop it down a little slightly? So.
I was trying to get it so everybody could read it.
Well, we'll move it up in just a minute,
Okay.
if you don't mind. This is called the continuum of depth of sedation, which I've been referring to quite often, from minimal sedation or anxiolysis. What is anxiolysis? It's just reduction in anxiety. It's a short term for that. And it shows moderate sedation, analgesia, which is commonly referred to as conscious sedation, and then deep sedation, which I've referred to where patients are essentially sleeping but can be aroused with vigorous stimulation, and finally general anesthesia, where they're not only sleeping but you cannot arouse them with reasonable stimulation or vigorous stimulation. And this were the definitions that were approved by the American Society of Anesthesiologists House of Delegates in October 2004 at our annual meeting, and subsequently amended in October 2009. So they're fairly current and represent what this organization, which is the organization that speaks for all of us anesthesiologists. And I think it's a very appropriate representation of the kind of physiologic responses that you would expect to see at the various levels of sedation. Now you can move it up. I'm sorry.
I've moved it up so it shows most of it. Could you explain what it indicates?
Well, what it looks at is the relationship between the level of sedation, or as I frequently refer to it, depth of sedation, and various physiologic changes in the brain response, that is responsiveness to verbal commands or other stimulation, tactile or otherwise. The airway, whether your airway is at risk to becoming obstructed. I think Dr. Schaefer showed some examples where the tongue can fall back and cause obstruction. So maintaining what we call a patent airway, which means air can easily go in and out of the mouth. Spontaneous ventilation, this is just your normal respirations, and whether they would be expected to be affected. And finally, cardiovascular function, which is your blood pressure, your heart rate, and other indices like cardiac output, which is not really measured. But we look at how they would, which of these various physiologic parameters would be expected to be affected at each of these levels. And I think the point you're trying to make, and I think the important point in this case, is that minimal sedation, as was provided by Dr. Murray to Mr. Jackson, would expect to result in a normal response to verbal stimulation, would not have an effect on the airway, would not affect spontaneous ventilation or cardiovascular function. So in essence, it would produce a reduction in anxiety and a mild level of sedation or sleepiness.
And exhibit quadruple E, that reflects minimal sedation?
Well, schematically, yes, I would say that if the levels of propofol and lorazepam, I don't believe midazolam is shown on this slide, but the levels of midazolam were...
It's there.
Oh, yeah, the levels are there, but the axis describing the concentration is not there. So
Well, the axis on the right, that describes the propofol concentration,
yes,
correct? The axis on the left describes the lorazepam.
right.
And when you're talking about minimal sedation, you're not taking into consideration this femoral vein concentration that we subsequently now realize was present at time of death.
Yes, I believe that's the femoral vein concentration of lorazepam, which was far higher than one would expect following 2 milligram bolus injections of lorazepam.
There's been we've heard a lot about the term